we turn to non-small cell lung cancer. And the field in lung cancer is one step behind the field of melanoma, but as you see, we'll see, the data are not less exciting. We have not yet gone into the treatment of how to treat resistant diseases, but how to expand the indication of immune checkpoint inhibitors. Second-line treatment of immune checkpoint inhibitors is now standard of care. There's data on nivolumab, pembrolizumab, atezolizumab, on survival advantage, fewer side effects, better quality of life as compared to chemotherapy. What is very important is that we seem to dare to take the word cure in the mouse, potential cure, because the long-term observation of patients treated in phase 1 studies suggest that a small proportion of patients might be cured. What we don't know is the duration of treatment, and I'll go a little bit into that. So this is a long-term result on patients treated in the phase 1 studies with pembrolizumab. You see patients with advanced disease on the right side, 16% 4-year survival, and these were heavily pretreated patients entering a phase 1 trial. The development of pembrolizumab was together with the development of PD-L1 as a biomarker, and I just show it here because at the end Professor Peters will talk about biomarkers in lung cancer at the closing of this symposium. But you see here the top line, a strong PD-L1 expression in the tumor is associated with a 4-year overall survival of 24% for heavily pretreated patients. Now, this is not just with this agent. The same data is available with nivolumab. 5-year overall survival of heavily pretreated patients of 16%. And these were 16 patients at risk. And if we look at those 16 patients, they have been followed up for 5 years or longer. Their treatment was 2 years, that is in blue, and then just follow up in yellow. 12 of those 16 patients still remain without disease, relapse-free at 5 years and at 3 years after discontinuation of nivolumab in this area. So that I'll do short because it has been really the issue of last year. Nivolumab, pembrolizumab, and atezolizumab are now standard of care for patients with advanced non-small cell lung cancer who have a progression after first-line treatment. Now this is the past, as we'll show you. But first I want to go to an example. I have brought it before, but to me it's really an engram in my treating patients. So this patient had a squamous cell carcinoma of the right upper lobe, bulky disease, bone metastasis. In hindsight, very strong PD-L1 positivity. He was treated with chemotherapy. The disease has not, there was not even a partial remission, but a cavitation of the major tumor. We decided for palliative surgery. He had palliative surgery. He then came back after palliative surgery with severe bone pain, lymph node and bone metastases. And we decided at the tumor board what to do. We said, okay, it's symptomatic. We do a radiotherapy, thoracic onto the sacral regions, and he started on nivolumab. He got 2 cycles, and then he came with a pneumonitis, which was very severe. At that time, it was not yet known in the hospital that, this is a pneumonitis due to immune-related side effects. Dr. Coronia had to fight very hard, so he doesn't go to palliative care. He came to the intensive care. The patient survived and came then back. And the question then was what to do after such a severe side effects. But when an oncologist doesn't know what to do, we ordered a PET scan. And essentially, the disease was gone. And of course, there was not any kind of indication for continuing treatment. And it was gone also in March 2017. I've seen the patient once more, and he was still in remission. He developed, unfortunately, severe depression. I hope this is not an immune-related side effects. The other engram for me was During his treatment, he was 64, he said, do I get my pension in rates or should I take the lump sum? I told him, take the lump sum. And after that, when he was in full remission, said, I don't know, it's only going to last for 10 years now. So it's, this transition from palliative treatment to potential curative treatment. Now, when we look at the second line of phase 1 data, I'm often asked, which is the best antibody? And I said, I don't know. The data we have, of course, is cross-trial combination is the grade 3 to 5 adverse event are very similar between PD-1 and PD-L1 inhibitors. Maybe there is a little less pneumonitis with PD-L1 inhibitors, but based on the earlier trials, there was no difference in the tumor response. Now, there is an issue, it's the duration of treatment. This was a US study. Patient who has been on treatment second line with nivolumab for 1 year, which is a selection. It's only those patients who tolerated, who had at least stable disease or objective response. They were randomized to stop the treatment or continuation, and unfortunately, the stopping treatment was associated with a much lower progression-free survival. The overall survival data is not yet in the public domain, the updated data. So at the moment, when we have a patient, we explain this and we continue the treatment. Now, I said immunotherapy is moving in oncology to other areas, and it's moving to earlier stages of non-small cell lung cancer. Consolidation immunotherapy with durvalumab after chemoradiation of stage 3 is now standard of care. We have interesting neoadjuvant approaches. There are 4 big trials, randomized trials of thousands of patients looking at adjuvant treatment, as has been documented be effective in melanoma. And of course, all those activities lead us to think that we should integrate immunotherapy for oligo-metastatic disease. This is the Pacific trial. Patient with stage 3 disease had chemoradiotherapy. They entered the trial to get placebo or 1 year of immune checkpoint inhibitor, and you see the difference of the curves. Now, to explain how important that is, every trial that has been done before over the last 20 years, the progression-free survival of anything after chemoradiotherapy was at best 9 to 11 months. Here it was 20 months. That's no wonder it's now approved as a standard of care for patients. We here in Zurich and with the ETOP group, we try to be more innovative and looking at the combination of chemotherapy, radiotherapy, and immune checkpoint inhibitors. The trial has now fully agreed. We now work on an amendment using 2 immune checkpoint inhibitors, ipilimumab and nivolumab in this context. Of course, as you know, in breast cancer, a lot has been learned of neoadjuvant treatment because after neoadjuvant treatment, you can take the tumor and look at the pathology. This is also an emerging field in oncology based on this trial, which was published in the New England Medical Journal. Patients who were surgical candidates had an experimental treatment, twice nivolumab, 2 weeks apart, and what was seen, a very good objective tumor regression, and resected specimens, often the tumor was replaced by just infiltrating lymphocyte. So this is an exciting concept. It is looked at also in a SAC trial, and here in Zurich we will do other trials in this area in the very near future. Which again now here brings together chemotherapy, immunotherapy, surgery, and pathology to get better results for the future. We here in Switzerland, in Zurich, we have the adjuvant trial. It's the PEARLS trial looking at Pembrolizumab in resected non-small cell lung cancer. The disadvantage of those adjuvant trials is it takes a long time to read out. I'm talked about oligometastatic disease and why not use all our means for those patients who had, let's say, not more than 3 metastases. Here we have designed a trial, as the group here together. We call it the CHESS trial, and hopefully we'll start the latest in January of next year. It looks at patients with oligo-metastatic disease. Patients are treated with chemotherapy, with SBRT, and they receive durvalumab during the whole treatment phase. Patients who are surgical candidates will have a radical treatment by surgery. Patients not surgical candidates will have radical treatment by radiotherapy. And the trial will be run in Netherlands, Spain, and Switzerland. Now, but 2018 is really the shift of immunotherapy for non-small cell lung cancer in first line of treatment. Pembrolizumab has been approved as single agent as a standard of care for patients with a high PD-L1 expression. It's called tumor proportion score higher or equal to 50%. Atezolizumab quadruplet treatment emerges as a new option for patients with non-squamous non-small cell lung cancer with a lower PD-L1 expression, in particular for those patients who require a chemotherapy after treatment of an EGFR TKI. Pembrolizumab combined with carboplatin and pemetrexes emerges as a new standard for care of patients with non-small cell, non-squamous cell, non-small cell lung cancer. And ipilimumab and nivolumab combination might be an option for patients with a high tumor burden. And we will hear of this in the last talk of this symposium. But I want to give the background. Patients with metastatic non-small cell lung cancer who do not have an oncogenic driver mutation. What was the treatment result in the older days compared to placebo? Chemotherapy versus placebo. And this is a meta-analysis, admittedly, to older clinical trials. I can summarize it easy. The effect of treatment with chemotherapy was an increase of the 12-month survival of 20 to 29%. This is in keep when we now compare the data with first-line immune checkpoint inhibitors. There's so many studies I have to break down in different groups. I look now at 3 studies which have looked an immune checkpoint inhibitor in metastatic disease as compared to chemotherapy. The KEYNOTE-24 studies looked at patients with a strong PD-L1 expression, and it made this the standard of care. CheckMate 26 study was negative, and the pembrolizumab study, KEYNOTE-42, I'll go a little bit in more detail and then do the summary on that topic. Now, this is the progression-free survival of patients with a high PD-L1 expression treated with chemotherapy or a single-agent immunotherapy, and at 12 months, it's 50%, 48% progression-free survival with a single-agent immunotherapy versus 15% like with the old-type chemotherapy. There's always still going to be a question, well, if you give immunotherapy second line, why do you need to give it first line? You can still use it second line. In this clinical trial, over 2/3 of the patients received an immune checkpoint inhibitor at the time of progression. Despite that, the overall survival benefit is still there for immune checkpoint inhibitor in first line. This is about sequencing or not of the treatment. The study with nivolumab looked at PFS and overall survival at 5% level of PD-L1. The study was negative. However, it taught us, digging in more into translational research, it taught us very well that the tumor mutation burden is important for the response to immune checkpoint inhibitors. You see the nivolumab arm, a high tumor mutation burden is of an advantage. In the chemotherapy arm, a low tumor mutation burden is of advantage. Now, this year on the ASCO came this trial that looks now all comers of patients. They're randomized to chemotherapy, the carboplatin paclitaxel, or carboplatin pemetrexed, or chemotherapy together with immunotherapy. And overall, there is a survival benefit, to pembrolizumab alone. And there is a survival benefit. The cutoff of the study was patient had to have at least 1% of PD-L1 expression. However, looking at the subgroups, it seems the whole benefit here on pembrolizumab was driven by the tumor group which have 50% or more PD-L1 expression and not by the lower group. So the conclusion is here, looking at single-agent immunotherapy, pembrolizumab single agent remains one standard of care, but only for patients with high PD-L1 expression, not for low PD-L1 expression. Now, I've switched to studies which looked at non-squamous, non-small cell lung cancer, and looked at the addition of immune checkpoint inhibitor to chemotherapy versus chemotherapy alone. 2 studies are in the public domain and 2 are press releases. The first study that was presented at ESMO last December, it looked at a standard treatment often used in the US, which is in red, carboplatin paclitaxel bevacizumab, and it compared in the first step on the hierarchical analysis the addition of atezolizumab, a PD-L1 antibody, to this chemotherapy. It showed a better progression-free survival, and the update showed a better overall survival by adding a PD-L1 antibody to a standard treatment. Looking at are there subgroups of patients who benefit most, it seems, yes, the strongest PD-L1 expression has the most benefit, but essentially it works in all patients. But it was a very striking finding was they allowed patients to enter this study who had an activating EGFR or mutational ALK rearrangement. And when you look here, the hazard ratio for those patients of adding atezolizumab to the standard treatment was 0.54. And I go to that in very detail because it's now how we approach our patients who need chemotherapy and have an EGFR mutation. You see, the importance here is really to use the bevacizumab and the atezolizumab together with chemotherapy for those patients, because on the treatment arm that did not have bevacizumab but only atezolizumab did not show a benefit in survival. So this has clearly emerged as a standard of treatment as we do it here. So atezolizumab quadruplet emerges as a new option for patients with non-squamous non-small cell lung cancer with no or low PD-L1 expression, in particular for patients with EGFR mutated tumors. Of course, we want to confirm that data and learn more, adding, what about if we have bevacizumab added to carboplatin and pemetrexed, would the result be even better? Or can we avoid the use of cis or carboplatin and reserve it for later on when a patient becomes resistant to the immunotherapy? And this is a new ETOP trial that will run in Asia, Spain, Switzerland, and in the UK. Now, the other important trial, there was Keynote 189. This trial looked at all comers of patients with metastatic non-squamous non-small cell lung cancer. Patients received either the standard treatment, carboplatin paclitaxel or cisplatin, or the same treatment together with pembrolizumab. And you see the overall survival benefit is dramatically. Overall survival, 60% at 12 months. You remember the 20% with chemotherapy alone in the olden days. Of course, the interest was, is there a subgroup of patients which profit most, or is there a group of patients which don't profit and shouldn't receive this combination? And when you look at the survival data, each degree of PD-L1 expression, all 3 groups profit from the patients. And again, this is now, we write Kostengutsprache, and we try to have our patient have access to this treatment with metastatic non-squamous non-small cell lung cancer. Toxicity. Yes, there is some emerging newer toxicity that wasn't seen so much with immune checkpoint inhibitor alone, and that is nephritis and hepatitis to grade 3 to 5 toxicity, and we have to be careful and monitor this in patients undergoing this combination. Now, for the insiders, the question is, patients now who have a very high PD-L1 expression, you use pembrolizumab alone or pembrolizumab and chemotherapy, as in the other trial. And essentially, we don't know yet, and we plan to do a clinical trial within ETOP to exactly answer this question. So pembrolizumab combined with carboplatin and pemetrexed emerges as a standard of care for patients with non-squamous non-small cell lung cancer with no or low PD-L1 expression, and for high PD-L1 expression, whether to use immunotherapy alone or the combination is to be seen. The last part of the trial is to combine immune checkpoint inhibitors and compare these to chemotherapy. And there's a trial of first the squamous cell carcinoma. The squamous cell carcinoma trial was done also with pembrolizumab and with atezolizumab, and the outcome essentially, to keep in time, is not much different. The addition of pembrolizumab to standard chemotherapy with squamous cell carcinoma is also associated with a survival benefit, and this survival benefit is also seen according in all types of PD-L1 expression. No expression, medium degree of expression, or high expression. So pembrolizumab combined with carboplatin, nab-paclitaxel or paclitaxel is a standard of care, a new standard of care for squamous cell non-small cell lung cancer. Now, here I come to the last set. These are studies that look at the combination of ipilimumab and nivolumab, a CTLA-4 inhibitor with a PD-1 inhibitor, or tremelimumab with durvalumab, a CTLA-4 inhibitor with a PD-L1 inhibitor, and they have very interesting results, but you have to wait to see those results when Dr. Peters will speak at the end of the session, where she summarized the new ways of immunotherapy and the importance of the biomarker, including the tumor mutation burden. So how do we now see today, how do we treat patients with metastatic disease after ESMO, AACR, and ASCO? Patients with non-squamous non-small cell lung cancer, they're examined for oncogenic driver mutation. If they're present, they're treated with targeted treatment. If there is no targetable alterations for patients with a very high PD-L1 expression, 50% or more, pembrolizumab is the standard of care. For patients with a lower degree of expression, the treatment is either pembrolizumab with platin and pemetrexed, or atezolizumab, bevacizumab, carboplatin, and paclitaxel, which is the first choice for patients with an activating EGFR mutation. Also, you might find out that very soon we will determine tumor mutation burden, not just in lung cancer, but in other diseases. And patients with a high tumor mutation burden might profit from the combination of nivolumab and ipilimumab, and we hear about that later on. For patients with squamous cell carcinoma, it's pembrolizumab. For patients with a high PD-L1 expression, it's pembrolizumab, carboplatin, and paclitaxel for the remainder of patients. And again, one might look at the tumor mutation burden, and for high tumor mutation burden, use the combination of immunotherapy alone with ipilimumab and nivolumab. And with this, I close, and I'll open for questions and discussion. Yes, Kevin.
Maybe I share.
Yeah.
So in the Keynote 042 data, you showed a very convincing effect of single-agent pembrolizumab.
Yes.
But what you didn't highlight was the fact that for the first 6 months, pembrolizumab was performing what looked like a good deal worse than the chemotherapy, and then the curves crossed. What's going on there?
Yeah, that's the discussion, because of course we compare those high PD-L1 expression across different trials, and the impression is the first trial, it took along for patient screening, and there were healthier patients that were entered. And now that everybody was excited, that even if a trial suggests you include only patients with PF performance status 0 or 1, there may be patients in who are, as we do in the clinic, 1.5 or 2. And it's an argument for those who said we use a combination at the start versus the single agent. Good, I see no more questions. I ask my